afternoon to one and all present here. I take a great indeed pleasure in giving this opportunity to speak about this paper. This is a clinical presentation of a case of PID turned out to be an ectopic pregnancy. A 27-year-old lady, married 1.5 years, presented to OP with chief complaints of lower abdominal pain and chief complaints of spotting PV from day 7 of the cycle and chief complaints of fever for past 10 days. It's not going. Yeah. It's not going.
Okay, use those.
Yeah. A menstrual cycle, age of menarche 15 years, regular cycles 3/28 days cycles, not associated with clots or pain, marital history, marriage since 1.5 years, non-consanguineous marriage, past history, no history of DM, diabetes mellitus, hypertension, bronchial asthma, epilepsy, thyroid, no history of any previous surgeries, personal history, mixed diet, bowel and bladder habits normal, family history nil significant. On examination, patient anxious in pain, febrile, hydration fair, pallor present, no pedal edema, BP 100/60 mmHg, pulse rate 68 per minute, CVS and RS no abnormalities, per abdomen soft, bowel sounds pleasant, and tenderness in right iliac fossa plus. Per vaginal, cervix pointing upwards, uterus retroverted, uterus normal size, on fornical tenderness present. Diagnosis, 27 years old lady, Cori ectopic pregnancy, bar Cori PID I suspect. Her blood investigations reveal beta HCG to be 6,725 MIU per ml, that's a mistake, sorry, 6,725. Ultrasound abdomen, a heterogeneous lesion of 5.6 into 3 cm in the left adnexa close to the left ovary can be seen. A ring lesion 2 into 2 cm with thick hyperechoic rim showing peripheral vascularity can be seen. For this patient, when UPT was done, it was negative. After this, the patient was taken for laparoscopic left salpingectomy. The ectopic pregnancy size, gestational sac was 2 into 2 cm in the left ischemo-ampullary region. Ectopic pregnancy. An ectopic pregnancy is a complication of pregnancy in which the pregnancy implants outside the uterine cavity. Usually, the ectopic pregnancy are not only visible, but are also very dangerous for the mother as it used to be followed by a massive internal bleeding. You can see the different sites where ectopic pregnancy has been placed. Implantation sites, extrauterine and uterine, tubal, ovarian and abdominal, tubal, ampullary, ampulla, isthmus, infundibulum, interstitial and cornual, and ampulla is the main region where it occurs about 70%, abdominal, primary and secondary, secondary intraperitoneal and extraperitoneal broad ligament, uterine, cervical, angular, cornual and caesarean scar. Etiology, any factor that causes delayed transport of the fertilized ovum through the tubes. Fallopian tube favors implantation in the tube mucosa itself, thus giving rise to a tubal ectopic pregnancy. These factors may be congenital or acquired. Congenital are about tubal hypoplasia, tortuosity, congenital diverticuli, accessory ostia, partial stenosis, elongation, intramural polyp, entrapment of the ovum on its way. Acquired causes include increased age, pelvic inflammatory disease, which accounts to about 6 to 10 times, tubal ligation, contraceptive failure, infertility, tubal reconstructive surgeries. Other factors also like cigarette smoking, diethyl silberstol exposure, fibroids, transperitoneal migration of the ovum. Acute ectopic pregnancy classical clinical presentation involves short period of amenorrhea between 5 to 8 weeks, positive pregnancy test, intermittent scanty vaginal bleeding of dark blood, abdominal pain. 3 triads of 3 A's, that is amenorrhea, abdominal pain, abnormal vaginal bleeding. Chronic ectopic pregnancy, patient would have recovered from the previous attack of acute pain. Patient may present with amenorrhea, dull aching, lower abdominal pain, vaginal bleeding, dysuria, frequency of micturition or retention of urine, and rectal tenesmus. Investigation which involves blood investigations, beta HCG. Special investigation involves ultrasound, laparoscopy, laparotomy, dilatation and curettage, cultosynthesis, magnetic resonance and imaging. Ultrasound sound involves transvaginal, transabdominal and color Doppler. Complication: massive bleeding, anemia, pelvic abscess, peritonitis, sepsis, pulmonary embolism, massive rectal bleeding or rectal passage of fetal bones. Maternal mortality includes 4% to 29%, whereas fetal mortality is notoriously high, ranging from 75 to 95%. Management includes medical management includes methotrexate. Administering a single dose of 75 mg IM injection of methotrexate is suitable treatment for ectopic pregnancy in cases where beta HCG is less than 3000 international units per ml. Surgery includes laparotomy and laparoscopy. Patients not suitable for medical management, medical therapy has failed. Patient has a heterotopic pregnancy with a viable intrauterine pregnancy. Patient is immunologically unstable and needs immediate treatment. Contraindicated in case of patient medically treatable. Patient having other medical condition that would make the risk associated surgery unacceptable. Laparoscopic indication more appropriate in stable patient. Shorter operating time, less blood loss, shorter stay in hospital, less need for analgesia. This is a salpingotomy which has been done with the incision. Milking or fimbrial expression, this is an idea in the distal ampullary or infundibular pregnancy. It has got increased risk for persistent ectopic pregnancy. Follow-up for conservative surgery with weekly serum beta HCG titer till it is negative. If the titer increases, methotrexate can be given. Summary: incidence of ectopic pregnancy is rising while maternal mortality from it is failing. Ectopic pregnancy can be diagnosed early with recent advances in immunoassay to detect serum HCG, high resolution USG, and diagnostic laparoscopy. There has been shift in the millimolpal ablative surgery to conservative fertility preserving therapy. Laparotomy should be done when in doubt. The choice today is laparoscopic treatment of unruptured ectopic pregnancy. Careful monitoring and proper counseling of the patient is mandatory. These are my references. Thank you.